monthly heads seminar where we present research in various phases. I'm looking forward to today's session, which is being led by Chanee Fabius, Andrew Jopson, Safiyyah Okoye, and MJ Wu had jury duty, so we're going to miss him today. But this is the product of years of work, which is really exciting, to link data from the National Health and Aging Trend Study to contextual factors. And so we have some wonderful progress that's been made. And I am going to turn it over to Dr. Chanee Fabius, who's an assistant professor in our department, to talk about this work, which is, as I mentioned, been sort of long in the making and has come out of one of our year one pilots. So you can sort of see the progress that's been made. And I'll just make a public announcement that we do, in part stimulated by this work, have a monthly contextual factors working group. So if you're excited about any of these ideas, feel free to reach out to me or to Nadia. We'd love to have you join. It's a hybrid modality with lunch in Hampton House for those of us who are in person, and by Zoom for those of us who are in other locations. And so with that said, I'm going to turn it over to Chanee.
Wonderful. Thank you, Jennifer. Let me go ahead and share my screen. And start. Can you all see? Okay, perfect. Well, thank you for the invitation to present our work, which examines the role of place and long-term services and support for older adults and highlights the NHATS geo-linkages and our use of them. So today, I, along with Dr. Safiyyah Okoye, who is formerly a Hopkins doctoral student and postdoc with our group, who's now at Drexel, Andrew Jopson, who's a doctoral candidate. And as Jennifer said, and I'll echo, MJ really wanted to be here. He is fulfilling his civic duty. We will share some of our work, which is a result of efforts that have extended over several years preceding the COVID outbreak with the involvement of a larger group. So I want to acknowledge especially NIA and the Head Center and NIMHD, which also sort of helped originate the pilot funding for this work. And I also want to acknowledge the team of people who have been instrumental in developing measures and projects related to this work, not listed here, but equally as important as John Mulcahy, who was instrumental in the launch of this work before he left to begin his doctoral studies at the University of Minnesota. And so I want to say, before we talk about our framework and sort of the work that we've been doing, but I'll just say a few words about our early work, more broadly, wanting to acknowledge the importance of the NHATS and NSOC platform as a preeminent data source of how older adults change or live their lives and accommodate changes in health and function. So these data are especially powerful in the context of their data linkages, which afford an understanding of how contextual factors shape their care experiences. And prior work has, for example, demonstrated that the presence, role, and capacity of caregivers affect the intensity and type of older adults' health services use in the hospital and home health care and long-term institutionalization by drawing linkages to Medicare data and claims. But we are living in an era where there is a growing appreciation of the importance of environmental and social determinants of health for health and well-being. So the NHATS census tract linkages, NHATS has availables down to the census tract, state, county, and otherwise, down to the census tract, provide researchers with exciting opportunities to shed light on the role of the neighborhood and community in shaping lived experiences with disability that our group has been thinking through. And so just to highlight some of the important work that has inspired our effort to develop a framework to examine and understand LTSS relevant environmental measures. We have a few publications that have leveraged the NHATS geo-linkages that predates the use of some of the work that we've done, and the MIGDA, which is the sort of online data portal that allows us to do this work rather than sitting in a cold room. I'm sure people remember that and still do that in some cases. These papers have primarily pulled in data from the ACS, linked to the NHATS participant census tract to include measures of neighborhood social deprivation and neighborhood broadband access. Other measures that we've used in the past include state level characteristics such as Medicaid generosity. So you'll see Dr. Safiyyah Okoye has led 3 papers. The first examining associations between neighborhood characteristics, neighborhood social deprivation, and broadband subscription, the use of telehealth use among older adults who are living in the community who use the internet. Finding things like older adults living in a neighborhood with the lowest versus highest tertile of broadband internet subscriptions were less likely to engage in telehealth. She also wrote a paper, led a paper examining the social and physical environmental fall risk factors in community living older adults, in addition to factors such as low income, financial hardship, and living in homes with disorder or disrepair, which are all sort of individual level factors. Living in a neighborhood with a high social deprivation, or at least at or above the 50th percentile, folks were more likely to experience recurrent fall. In her third paper, she did some similar work focusing on the differences of risk factors for older adults with and without dementia. This study identified that living with a spouse, vision impairment, so on and so forth, were some factors that were related to experiencing a fall among community living older adults with dementia. Interestingly, living in a neighborhood with a high social deprivation was associated with lower odds of experiencing a fall among older adults with dementia. And then I have led a paper examining the associations of the use of paid help, between the use of paid help and care experiences among Medicare and Medicaid dual enrollees with and without dementia, and pulled in state level information such as Medicaid generosity. And Dr. Julia Bergdorf also has leveraged these linkages to examine the use of patient portals in older adults and their family caregivers, pulling in neighborhood characteristics, both representative of folks who are living in neighborhoods, the percentage of broadband access in a neighborhood and the percentage of residents living in poverty, finding that older adults with at least one caregiver using their patient portal were more likely to live in neighborhoods with broadband access. So taken together, I know that was a lot. These papers provide a glimpse of what is possible using the NHATS geo-linkages and present opportunities for broader examination of environmental contributors to person-reported experiences. And so today we're going to present a novel framework to understand LTSS relevant environmental characteristics. By way of background, of course, it's important to acknowledge the older adults that we're referring to throughout our work. So there are more than 10 million older adults living in the US receiving help with daily activities to accommodate physical or cognitive disabilities. Many of these older adults are relying on LTSS to help with routine daily activities such as bathing, dressing, etc., which can be provided in traditional community settings, residential care settings, so on and so forth. As older adults with disability are typically living and managing co-occurring chronic medical conditions, the availability, quality, and coordination across services is also important. Much of LTSS is publicly funded by Medicaid and less often covered by Medicare. So this, along with the availability, quality, and accessibility of LTSS variability across geographies, results in individuals and families having to navigate LTSS access and provisions within a fractured healthcare system. And so there's a growing appreciation and health outcomes are affected by the use of services, individual factors, and aspects of the environment in which people live. But little attention has been paid to the role of LTSS relevant environmental characteristics. Prior work examining these relationships have used administrative data rather than self-reported data. Additionally, existing disparities such as those rooted in racial segregation and nursing home residents and neighborhood disadvantage were further exacerbated by the COVID-19 pandemic, when we saw high rates of COVID-19 infections and mortality experienced by older adults from racial and ethnic minoritized groups and those living in poverty. So I'm gonna invite Safiyyah to come on and talk a bit more about our framework at this time.
Okay. Hello. Everyone can hear me? Yeah, okay. So a key contribution of our work is the development of this conceptual framework, identifying environmental domains that contribute to LTSS access, care quality, care experiences. In order to, this went through many renditions, but we drew on several health equity and disability frameworks. And because we knew it was going to be closely related, or we were going to use it in conjunction with NHATS, that also we drew on the NHATS framework also when putting it together, in order to conceptualize quality of life and care as resulting from relationships between individual characteristics and then different domains of environmental attributes. And much of our foundational work has been building this framework to accommodate broader LTSS relevant factors. We had the opportunity to present this framework last year, it might have been a couple years, was it last year at Academy Health? And then we have a manuscript that's in the peer review process. So hopefully that it goes smoothly. And here is a pretty simple version. It's changed a little in the peer review process, but it has, so you can kind of see it looks similar to the NIH health disparities framework in terms of we have environmental, we have key populations at the top that often experience disparately poor LTSS care experiences, including racial and ethnic minority groups, socioeconomically disadvantaged groups, rural populations, disability populations, and sexual and gender minority groups. And then on the y-axis, we have environmental domains. So social and economic domain includes factors that influence the distribution of goods and services and social networks. Healthcare and social services delivery encompasses the structure and generosity of relevant programs and policies. And then the built-in natural physical environment includes transportation and land use, physical communication infrastructure, and physical housing. And then we differentiate 3 different environmental levels. So societal, community, and then the individual or individual household. And we, these can be kind of looked at, there's some flexibility in how you decide for if you were to use this, what the societal level or the community level, the individual or household level would be, but it's this idea of going from a macro to a more micro. And in our uses of it, you can see societal includes, we use state level mostly in the analyses that we're going to present. And community, we used let's see, I think some neighborhood level, and then individual household is what we brought in from the NHATS. And additionally, because of the effects of accessing services and being exposed to LTSS relevant policies, we acknowledge considerations for quality, which range from quality of care to adequacy of policy implementation. And I'm going to invite Andrew Jopson to discuss a few measures specifically related to his dissertation work that are also part of our LTSS framework.
Great, thanks, Safiyyah. So there's kind of a lot of different measures within this framework, and I just kind of want to walk us like one example of ways that we've constructed some that is specifically moving some of the work that I'm doing forward. And so an example measure capturing the healthcare and LTSS financing domain at the societal level are assembled measures of the Medicaid-funded LTSS environment, specifically the presence of managed long-term services and supports, or MLTSS, for older dual enrollees. And the purpose of these measures is really just to capture the presence and specific program features of these programs that serve older dual eligibles. So next slide, Chanee. So to assemble measures for MLTSS, it's pretty scrappy. We leveraged the Medicaid Managed Care Enrollment and Program Characteristics Report for 2015, which includes detailed information about each state's managed care programs, including MLTSS. Next, Chanee. And we use this report to identify state and county level information about where MLTSS programs exist and specific features of these programs. Next. And some of these features that we've gathered, include enrollment type. So like whether a program had mandatory or voluntary enrollment for this population, the federal operating authority overseeing the implementation of MLTSS, number of programs in a county, because some we found have more than one. And then also just whether the program had any carved out benefits that might be specific to our framework, including HCBS or mental and behavioral health. Next slide. And so after we've assembled these measures, we use them to really assess the relationship between Medicaid-funded LTSS policy features and outcomes among older dual enrollees with LTSS needs. And that's kind of specifically the work that I'm moving forward. The next step really in this process is there's these reports fortunately exist for other years that map really well with NHATS. And so we'll be building out some of these measures for other years from 2011 to 2022. And so for each of these measures, this is just, kind of like one specific Medicaid funded LTSS characteristic. We've assembled like a repository that has a lot of detailed documentation about how each of these were assembled, different decisions and choices that we've made. That's available as part of our contextual measures working group. So I think I'm now supposed to pass it to Chanee, who's also going to talk about some of the other measures that we've assembled for our framework.
Yes, and I will try to do as good of a job as MJ does in explaining this. And I really would like to lift up MJ because this has not been an easy undertaking to do the linkages, be well versed in the unit that are being linked and what's being represented. And so his work is absolutely appreciated. And all of this, it really would not have been possible without him, his hard work and dedication and interest in doing this work. And so from our NHATS sample, so our sample included 2,411 community dwelling older adults who received assistance with household mobility or self-care activities. We excluded people in the nursing home. So we community refers to traditional community setting or residential care setting. So this list on the right is not exhaustive. There's a lot of measures that are included in this list, but we compiled a number of measures that align with our framework that Safiyyah just reviewed across varying geographic levels. And for each measure, we pulled data for the smallest geographic area. So for example, measures from the American Community Survey reflected the census tract, which is widely used to reference neighborhoods. So one measure we pulled in was percentage of neighborhood residents who are unemployed. Another was percentage of neighborhood residents on public assistance, things like that. We also have used the Neighborhood Social Deprivation Index by Butler and colleagues. Next, the Bureau of Labor Statistics provided information about the direct care workforce and hourly wages at the metropolitan statistical level, area level, and then state measures finally were included information such as the share of Medicaid long-term services and supports expenditures allocated to home and community-based services, otherwise known as Medicaid HCBS generosity. Other state level measures reflected the enactment or the presence of a policy or regulation, such as the presence of paid sick leave in a state or family leave, as well as a few others. And so this slide describes the categorization of the geographic measures that we included in our analysis. You'll see that our measures are organized according to the domains. And as well, we don't have the subtitles in here, but they're also across the different levels of geography from our framework. So for continuous measures, those without established cut points were categorized by tertile for our analytic sample, and others were categorized as dichotomous measures. And so we examine associations between LTSS relevant environmental characteristics and 3-person reported care experiences of older adults. So first, adverse consequences due to unmet need refers to the negative consequences due to no one being able to provide help or assistance, or the activity being too difficult to perform alone. So we include self-care and mobility adverse consequences. So self-care would be going without eating, being unable to shower, all the way to going without getting dressed. Mobility, having to stay in the house or having to stay in bed because no one is there to help you, or the task is too difficult to perform alone. Participation restrictions refer to being unable to visit friends and family, attend religious services, attend club meetings or group activities, or go out for enjoyment due to health and functioning reasons, for the subset of participants who reported each activity as very important or somewhat important, as in prior work. And that is one dichotomous measure for any participation restrictions. And then subjective well-being was a composite measure of 6 items reflecting how often in the last month participants reported feeling positive and negative emotions, being cheerful, bored, full of life, or upset, and self-realization. The responses were some that the composite measures range from 0 to 20, and the scores were dichotomized, to contrast the highest quartile well-being. So a score of 18 or greater with lower scores, 17 or greater, or 17 or lower, excuse me. And so we conducted bivariate analyses to examine comparisons between LTSS environment characteristics and those 3 relevant care experiences. The darker color on this chart, it just refers, the darker the color, the stronger the association. And this chart shows which LTSS relevant characteristics are associated with care experiences of community dwelling older adults. And I think rather than going over each individual measure, the most the way that we've been interpreting some of these is the patterns that we see. So socioeconomic characteristics are more often associated with experiencing adverse consequences due to unmet need. Healthcare and social service delivery characteristics are more often associated with participation restrictions. And then there was variation across healthcare and social service delivery and built in natural physical environment for low subjective well-being. And so our study advances a conceptual framework and provides evidence linking LTSS relevant environment domains to meaningful person-centered outcomes for persons with disability. We find systematic variability across domains of LTSS relevant environmental characteristics and the strength and directionality of relationships. And neighborhood measures more often associated with adverse consequences due to unmet need might be an indication of the more unequal and more pronounced prevalence of disability among low income and minoritized older adults that may compound financial accessibility and gaps in care quality. We also recognize that addressing family and neighborhood socioeconomic well-being requires time for neighborhood effects on health to emerge. Still, interventions might follow the example of studies such as Capable, led by Dr. Sarah Zanton, which targets lower income older adults living with disability with a goal of independence at home. And then state level characteristics we found were more often associated with participation restrictions. So this reinforces the relevance of state strategies that invest in HCBS or home and community-based services, such as managed long-term services supports, as Andrew discussed, paid family leave, and direct care worker wages. This further emphasizes the need for policymakers and providers to focus on increasing compensation for direct care work, as has been done in demonstrations that improve career trajectories for workers through training, certification, and increased mentorship and pay. And then the other point to highlight is that our measures may provide greater context to what is currently understood about older LTSS users' care experience via instruments like the National Core Indicators of Aging and Disability work that collects information on outcomes like participation, well-being, and routine daily activities, but the findings are limited to a select number of participating states and don't account for geographic characteristics. And so, of course, we acknowledge several limitations. This is a cross-sectional study, so we were unable to assess causality. We have limited measures related to the built and natural physical environment, and this is something that we learned as we were doing this work, is that the information and data reflecting state level policy measures and social and economic neighborhood factors are much more easily accessible than measures that reflect the built-in natural physical environment. So, of course, there's a more concerted effort needed to obtain that data. And so the other limitation is that we cannot comparatively assess the importance of specific levels, of the societal, community, or household environment. But findings present opportunities for the next steps that move forward toward more comprehensive analyses that would draw on multiple levels. And then, of course, our data preceded COVID-19. And so, of course, moving forward, one of the things to take into consideration are changes to long-term services supports during that time. And so finally, our framework conceptualizes the LTSS relevant environmental characteristics and demonstrates its utility by quantitatively examining relationships between environmental contexts and person-reported care experiences among community living older adults with disabilities. Our hope is that this framework serves as a platform for further refinement and investigations to advance our knowledge of the pathways by which LTSS environment context shapes the care experiences of individuals with disabilities. And with recent efforts devoted to better understanding social determinants of health and the push for family-friendly policies, findings provide a direction for future research as well as policy and practice that will strengthen LTSS and improve quality of life for older adults with disabilities. And of course, the next step is to do similar work using the NSOC and examining family caregiver experiences. And that is our presentation. So I will stop sharing and happy to take any questions, comments, feedback. It's all appreciated.
Looks like there's a question in the chat from Harriet about.
I'm happy to say that. Yeah, it was just about the analysis. I think you kind of alluded to it in the final limitation. So firstly, thanks so much. This is amazing. But it was just about, I think you alluded to it in the last slide, but it's thinking through how do you think about the NHATS sample in terms of if you wanted to do multi-level analysis to kind of get at the relative contribution of individual versus various contextual levels. I'm thinking particularly in terms of figuring out mechanistically what's happening and therefore where your targets for your intervention are going to be. Is that possible?
Yeah. Thanks, Harriet. I think that that's a really good question and something that we're still thinking through in terms of multivariate analyses and things like that. I will say that Dr. Vicki Friedman and one of her colleagues will be at our contextual factors meeting in June, talking about this specific issue. And so anyone interested is welcome to come because they really are the experts in the sampling. But I appreciate that. That is something that we are thinking through carefully. Catherine?
Yeah, this was amazing. I think the framework is incredible. I was not sure. So based on the comment in the chat, like where would sort of access to healthcare fall in the framework? Because I can imagine that is relevant to LTSS, but just thinking about like even just like both access to like hospital or outpatient care or even like a CVS pharmacy, I could imagine would impact people's like what services they're receiving and what they need. And so I was just wondering if that, where would you put that in your model?
You know, that's interesting. I imagine that it could happen across a few different levels. And I think, you know, about the proximity, like access as a matter of proximity. That's one way to think about it. Access as a matter of insurance, right? Provider. That's another way to think of it. And so I do, you know, appreciate your point about considering some healthcare measures. And we can think more carefully about that. I don't know if others have thoughts.
Almost like equating it to sort of like food desert work. So like, are there like I'm not as familiar with the literature, but almost like pharmacy deserts where would be something that's kind of interesting to think if people are using services more because they have trouble accessing or vice versa, but kind of that was where my head was going in terms of maybe like geographic work.
I read a really interesting paper. I'm sure lots of people on this have already read it, on pharmacy deserts that was done last year, which I can share.
Oh, thank you. Thank you. Thank you.
Yeah, that's I just chiming in for Catherine's question that we did, we made that second domain, healthcare and social services delivery, thinking like recognizing that healthcare services were important. I think what we outlined is more of the LTSS or like what we included in there, but I think you could fit it in there. I think there's flexibility on where you put it. And it also, if it's the outcome, for example, right, then you might think about it differently than if it's a predictor or something. But I think it would fit in there somewhere. And then it's a good question about, is it, you know, insurance rates, for example, which could be looked at as state level for perhaps was there Medicaid expansion or something like that, versus is it more this geographic neighborhood? How far is it to a healthcare provider's office or a hospital? So I think that's a great question to play with this with. Yeah,
and I will say that one of the measures that we did not was not shown today was the concentration or Medicare Advantage penetration. So for example, that's at the state level. That's something that we're able to access, I think, via like Kaiser report, Kaiser Family Foundation report, so on and so forth. So yeah, no, thank you for that.
Looks like Elizabeth Stone has a comment. Elizabeth, I don't know if you want to add to the comment in the chat.
Oh, no, I was just thinking of other ways to think about kind of this like distribution of healthcare services.
I'm not familiar with this one. I'll take a look. Thank you. Other questions, comments, feedback?
Looks like Harriet has another resource. Thank you, Harriet. I guess just along the lines of the pharmacy desert comment, I wanted to just acknowledge that a lot of, you know, the focus of the measures that are included here are, as Chanee mentioned, sort of more directed around thinking about person and family reported experiences related to long-term services and supports. But the library of measures could be used in a whole host of ways across different data sets, you know, like Medicare fee-for-service claims or Medicare Advantage, or, you know, there's any. So we, you know, this is sort of a first foray, and we are very trying to do a good job of documenting the data that we're collecting so that others can use it. It's especially the direct care worker linkages, which are sort of at a different geographic level.
Looks
You have
like
another question,
Catherine.
Catherine? Yeah.
Sorry to hog the floor.
No, go.
I was thinking for like future policy implications. I know the National Committee for Quality Assurance has measures and programs in the LTSS space, and so maybe like an interesting path of policy exploration to connect with them and see if like what their measures are currently and how it could be informed by your framework.
Wow, that sounds fantastic. I think there, it's clear that the measures in the LTSS space are way behind what's available in healthcare, just in part because of data availability. And so I think, this was in part just trying to think about how we could build on available, the amazing richness of NHATS. But I think if there's a way to sort of broaden what we're doing and have it inform policy, that would be of great interest to our group.
And
Yeah, that's a great
Norma
idea.
put a comment and saying that Medicare Advantage penetration is available at the county level, and as well as included the link. So thank you for that. Danielle Powell, did you come off of mute on purpose?
Nope, sorry about that.
Okay.
Didn't do that.
Because you came off of
Managing
mute
a
and you walked
handful of
away.
things. I'm
Like, I
muting
think
again.
you did that.
Great. Well, if there are no other comments or questions, we are, Harriet.
Mhm.
Yeah, I also didn't want to hog the floor. I know this is kind of outside the scope of LTSS, but it's just something I'm really interested in. So I thought I'd use this opportunity to ask. In terms of social capital, social cohesion, do people know of kind of measures that are available that live outside of the surveys on social capital and social cohesion in communities?
That's a great question.
Yeah, I don't know. I don't know. The social cohesion measure that we had was actually from NHATS. So it was not it wasn't one that we leveraged through the linkages, but I'm not sure. I'm not sure if the answer to that question is probably something worth looking at.
Does anyone else on the call have thoughts? I'm looking at Doug Wolf's square here.
Well, not on that specific issue,
Okay.
but I mean, I'm very interested in the findings about paid family leave and paid sick leave. I'm doing some work of my own on the same topic. So I couldn't tell if that table that showed groups of variables that were included in models and p-values, p-levels for significance, is that part of a paper that you're willing to share around yet, or is that being written, or is that the one that's under review? Or
that's the one that's under review.
Okay.
That's the one that's under review. But what I will say is that and I should have spent a little bit more time on that slide, but the presence of that group of state level policies or what have you in the healthcare services domain were associated with less likelihood of experiencing participation restrictions. Whereas on the neighborhood side, higher deprivation, essentially deprivation, higher rates of public assistance, so on and so forth, were associated with experiencing adverse consequences due to unmet needs. So, the paid family leave piece is really interesting to us, especially given all the discussion around it recently. And so yeah, but the paper is under review now.
well, please send it out as soon as you get it accepted, okay?
Absolutely. Thank you.
And it looks like Jenny Markle shared a paper. I'm looking, Jenny, do you know if, whether that data is widely available? Do you want, I'm just trying to read the paper.
Yeah, I actually hadn't read it either, but I knew that Elizabeth Bradley's team had done some work on this. It looks like they used the social capital index, which is available at the county level. But I haven't used that, so I don't have more information on it.
Well, thank you.
Thank you. What a great group.
I know, I'm saving the chat.
Yeah, these are great resources.
I can send the chat out to everyone if afterwards, if that'll be helpful.
Thank you, Nadia.
Well, if there aren't any other questions or comments, then we can certainly give you back about 15 minutes of your day. For anyone who's interested, I think our next meeting, when is our next meeting?
The first Thursday in May. I don't remember
Okay.
the date, but it's the first Thursday of
Okay.
every month.
And then the
May 17th, I believe, yes.
May 17th at noon. And then in June, when is the date in June?
So we have one on May 17th at noon. Then we have one. We also have one on May 23rd. We added an extra one in. That'll be a pilot seminar, and then the one in June is on June 21st.
Great, and that's the one that we have Vicki Friedman and Mengao Yu.
We're talking about different meetings, Jennifer.
Oh, we are.
Yeah.
Nadia's talking about the head seminar.
Oh, sorry.
Sorry for confusion. Anyway,
Sorry, yes, I'm
send
sorry.
us a note if you're interested in coming to the Contextual Factors Working Group, and especially if you're interested in thinking about the sort of the weights and the sampling strategy and how that fits in. Thanks everyone for a great conversation. Love the cross-fertilization of ideas, and we'll look forward to seeing you next month.